Today in this 1 hour time, we will be discussing about a very important guideline which has been recently released, the GTG of small for gestational age. Okay, so this becomes very important in the antenatal module because in this guideline, they have really made significant changes. So now in all the SBAs and EMQs, you will have to answer according to this new GTG. So let's focus on the very important changes which have been made in this. So as always, let's start with the quote that strive not to be a success, but rather to be of value. So always study, always go through everything thinking that how it adds importance to my practice, to my life, other than passing any exams. So today's topic, mainly I will be covering under 5 headings. First of all, let's see what important changes have been made in definitions and terminologies. Next, risk factors have been varied significantly. Here, risk factors we will talk about and some risk reduction strategies which GTG advises. Then we will learn how they have stratified the women into low risk, moderate risk, and high risk, the pregnant women, of course, and how they have to be undergo surveillance so that a proper diagnosis of SGA or FGR can be made timely. Then, once diagnosis has been made, that is after diagnosis, how to monitor them, how surveillance will be done once the diagnosis is made, and how the timing of birth will be decided. Again, just like here, till the time diagnosis hasn't been made, the pregnant women are classified into low risk, moderate risk, and high risk. And once diagnosis is made of small for gestational age or FGR, then they are classified either into SGA, that is small for gestational age, or into FGR. And surveillance of early FGR and late FGR is a bit different. So we will talk accordingly. And then the mode of birth. So let's first start with definitions and terminologies. So here, as everyone must be well aware of this, that if fetal size is between 10th and 90th centile, then it is known as appropriate for gestational age. No confusions in this. This was earlier also the same, now also the same. But now strict importance is given to differentiating between SGA and FGR. That is small for gestational age is whenever fetal size is getting less than 10th centile, we are classifying as small for gestational age, but it should be more than 3rd centile to keep it into the definition of small for gestational age. If fetal size is between 3rd to 10th centile, then it will be known as small for gestational age. But now if fetal size or abdominal circumference drops less than 3rd centile, or then it will be called as fetal growth restriction. Number 1 criteria. Or if fetal size is less than 10th centile, but accompanied with Doppler abnormalities or any evidence of placental dysfunction, either in the form of abnormal uterine artery Doppler or abnormal umbilical artery Doppler, then also it will be called as fetal growth restriction. So any fetal size less than 10th centile, but more than 3rd centile and no Doppler abnormalities is small for gestational age. Any fetal size or AC less than 3rd centile with or without Doppler abnormalities is FGR, or fetal size between 3rd to 10th centile with Doppler abnormalities is again FGR. So SGA is somewhat benign, FGR becomes more pathological, we can say. Now here, FGR has been divided into early FGR and late FGR, that is fetal growth restriction. Early is less than 32 weeks, that is 31 plus 6 weeks, and late is from 32 weeks onwards is late FGR. One more terminology has been mentioned, that is static growth. Static growth means no forward growth velocity in effective fetal weight or abdominal circumference measured at least 14 days apart. So this is one more change. Earlier, they recommended not to take biometry before 3 weeks at all. But now once FGR or SGA is diagnosed, they monitor through effective fetal weight or abdominal circumference every 2 weeks. So if in these 2 weeks there is no forward growth velocity, then they describe it as static growth. So this is one more important terminology. Now, focusing on a few changes again. In earlier guideline, previous SGA, any SGA was a major risk factor. So earlier they had stratified into minor and major risk factors, but now minor and major is gone. Now becomes low risk, moderate risk, and high risk. So now FGR in previous pregnancy is a risk factor only if any of these three are present. That is, either birth weight is less than 3rd centile in previous pregnancy, that is FGR in previous pregnancy, or early onset preeclampsia, or any fetal growth restriction necessitating birth before 34 weeks. That is sort of, you can say, any sort of placental dysfunction evidence was there in previous pregnancy. Then again, it becomes a high risk in this pregnancy. Next, birth weight less than 10 centile with evidence of placental dysfunction again. So this is clear-cut FGR. Any birth weight less than 3rd centile or birth weight less than 10 centile with placental dysfunction, all these are again the criteria which are necessary to define FGR. In previous pregnancy, if there, then it is a risk factor. Again, I'll be talking about this further in detail. Now, emphasizing a bit on pathophysiology, any small fetus will be either normal, that is constitutionally small, means there is no pathology as such, but just like that, the fetus is small. Or there may be either non-placenta mediated growth restriction, that is, there is a structural or chromosomal anomaly, there is any fetal infection like CMV, we read that in CMV, IUGR occurs. So that is non-placenta mediated growth restriction, or any inborn errors of metabolism. Or it may be placenta-mediated growth restriction, placental dysfunction. Now, what all things can affect placental transfer of nutrients? It may be maternal factors in the form of low pre-pregnancy weight, undernutrition, substance misuse, or severe anemia. Things like that will affect placental transfer of nutrients. It will fall in placental dysfunction. Or any medical conditions affecting placental implantation and vasculature. As we all know, placental vasculature is severely affected in preeclampsia. Any autoimmune conditions which again aggravate the condition of preeclampsia, or independently they cause placental dysfunction. Any thrombophilias, renal or cardiac disease, diabetes and essential hypertension. All these are risk factors for placental transfer of nutrients, and hence it may be responsible for small fetus because of placental dysfunction. So you have to clearly think that whether it is non-placental mediated or placental mediated. And usually things like these will cause early onset FGR because these will be present right from the beginning of pregnancy or from the 2nd trimester itself. And up to 32 weeks, it's early onset FGR. So these things are mainly responsible for early onset FGR. Now, in general population, what all they have mentioned to reduce the risk. So just 2 main things they emphasize in general population. First, they have paid attention to smoking. So those women who smoke, they highly emphasize to reduce smoking in pregnancy by identifying those who smoke with the help of carbon monoxide testing. This is new in this. So they use carbon monoxide testing to identify the women who smoke, and they provide in-house treatment to smokers in pregnancy from a trained tobacco dependence advisor. So this is offered to all smoking pregnant women, unless and until they opt out by themselves. Opt-out referral process is there, but otherwise they offer to all, just like HIV types. So they offer to all smoking pregnant women carbon monoxide testing, and trained tobacco dependence advisor help them to stop smoking. Another important thing which they have mentioned as a risk reduction strategy is that all women should continue to take the recommended 10 microgram per day of vitamin D throughout pregnancy. Remember, vitamin D dose in pregnancy is 10 microgram every day. and 400 microgram per day of folic acid in low-risk women means, of course, preconception and at least for the first 3 months of pregnancy. So these two are routine risk reduction factors which they advise. Increasing the dose of vitamin D, increasing the dose of folic acid in low-risk women has got no otherwise effect on reducing the incidence of SGA or FGR. So this dose you all need to remember. Now let's come to the most important two topics. That is, first is the screening. Just like in previous guideline, the two main tables of SGA were there. One was screening, how to identify and diagnose at an appropriate stage. And second was, once diagnosed, how to classify them, treat them, or in fact, monitor them and decide the timing of birth. Similarly, here are also two main tables. One is surveillance pathway following risk assessment. So first, as I said, minor and major risk factors have been eliminated. Low risk, moderate risk, and high risk are there now. So first, let's see if there are no risk factors at all. Means woman is absolutely like primary gravida or any gravida, but with no risk factors, then risk assessment is to be done in all. Risk assessment to be done in any pregnant woman coming to antenatal clinic by booking visit or minimum by 14 weeks. So 14 weeks, they have mentioned that by 14 weeks, risk assessment should have been complete risk assessment for any factors, any high risk factors have to be done. Then this is to be offered to all women, whether high risk, low risk, moderate risk, anomaly scan, just like we all know. And we evaluate the effective fetal weight. If it is more than equal to 10th centile, then it is all right. That is, we can undergo routine surveillance through serial measurement of SFH, that is symphysiofundal height, just according to NICE guideline. So here I have written from NICE guideline that what routinely is done, offer SFH measurement at each antenatal appointment after 24 weeks for women with singleton. And if there are concerns that baby is large for LGA, then ultrasound is suggested. Similarly, if it is concerned for any fetal growth and well-being that SFH is small, then again, the lady is referred for further monitoring. Now, here, this gestational age is given in GTG that symphysiofundal height measurement should be started routinely after 24 weeks, but at least first measurement should be carried out by 28 plus 6 weeks, not later than that. And yes, one more important thing is do not routinely offer ultrasound scans after 28 weeks for uncomplicated singleton pregnancies. So if routine lady is there, anomaly scan was okay, if fetal weight was also okay, and on SFH, there is no suspicion of low or high growth, then you can easily offer a routine SFH measurement without offering any ultrasound scan. Next comes the chance of moderate risk factors. Now, which are moderate risk factors here? Previous SGA is a moderate risk factor, not a high risk factor. Or previous stillbirth, where the baby was appropriate for gestational age. These two fall in the category of moderate risk. Again, this is for obstetric history. In current risk factors, any smoker. Earlier, the number of cigarettes were stratified into major or minor, but now any kind of smoker, any drug misuse, any woman more than 40 years of age at booking, 40 or more at booking, BMI less than 18.5 with or without other features like, and also other features, means some may be constitutionally small, but less than 18.5 BMI and other features like eating disorder, bowel disorder causing weight loss, or gastric bypass surgery. Not all bariatric surgeries, but especially gastric bypass surgery. Or any previous preterm birth or second trimester miscarriage, which is placental mediated. The evidence of placental dysfunction should be there to classify it as moderate risk. So now for these ladies, what will you do? First, if any placental mediated factor is there, or any other criteria of NICE guideline, hypertension in pregnancy is met of starting aspirin, then they have to be started on aspirin. And they require a one-off SFH measurement at 28 weeks first. And then if anomaly scan and if fetal weight were more than 10th centile on the mid-trimester anomaly scan, then they have to undergo serial ultrasound scans from 32 weeks onwards every month, that is every 4 weeks until delivery. So for all moderate risk women, one SFH measurement will be carried out at 28 weeks. And then if all is good, then from 32 weeks, you have to summon them for serial ultrasound scanning every 4 weeks until delivery. In low risk women, no ultrasound scan was required. Only SFH measurement was to be continued till delivery. Here, serial ultrasound scans from 32 weeks every 4 weeks until delivery. Now, for surveillance pathway for high-risk women. Now, who falls in high-risk women? Maternal medical conditions like CKD, hypertension, any autoimmune disease like SLE, APLA, or any complex cardiac disease, valvular especially, or MI, recent MI, or previous FGRC. Here, in moderate risk factor, it was previous SGA. Here it is previous FGR, that is less than 3rd centile with or without placental dysfunction, and hypertensive disease in a previous pregnancy, or previous SGA stillbirth. Appropriate for gestational age stillbirth is moderate risk, but small for gestational age stillbirth comes in high risk. Now, these parameters you have to remember that if PAPA is less than 5th centile, inhibin A or alpha fetoprotein is more than 2 mom, ecogenic bowel is there as an isolated finding even, then it becomes high risk. Significant bleeding, fetal weight less than 10th centile at any time on mid-trimester anomaly scan especially, or single umbilical artery identified on mid-trimester anomaly scan. So these all are high-risk factors. Here again, you will consider prescribing aspirin, 150 mg at night from 12 weeks onwards or less than 16 weeks as appropriate, especially for those with previous hypertensive disease or previous FGR. Wherever there is evidence of placental dysfunction, aspirin has to be added. Then in these high-risk women, what will you do? You will do uterine artery Doppler. In previous guideline, for 3 minor risk factors you were doing. Here, forget those things. For all high-risk women, you have to do uterine artery Doppler at the time of routine anomaly scan. Okay. Now further, you have to decide on the basis of fetal weight and uterine artery Doppler at the mid-trimester anomaly scan. On the mid-trimester anomaly scan, if both these things are normal, that is normal uterine artery Doppler and fetal weight is good, then you can advise them serial ultrasound scanning from 32 weeks, every 2 to 4 weeks until delivery. If uterine artery Doppler is normal, but fetal weight is less, means just fetus is small, but uterine artery Doppler is okay, then instead of this 32, you have to do serial ultrasound scanning from 26 to 28 weeks until delivery. Here you have to individualize that at what intervals you will call her. But remember, from when you have to start? From 26 to 28 weeks you have to start. If all is good, you have to start from 32 weeks, every 2 to 4 weeks. But if fetal weight is less, you have to start from 26 to 28 weeks itself. So these two things were, then uterine artery Doppler is normal. Uterine artery Doppler is abnormal, but fetal weight is fine. Then again, you have to do serial ultrasound from 28 weeks, every 2 to 4 weeks until delivery. And what about both are abnormal? That is, uterine artery Doppler is also abnormal and fetal weight is also less than 10 centile, AC or fetal weight. Any of these is less than 10 centile. Then you have to discuss with fetal medicine because something is really serious. You may have to offer invasive diagnostic testing, serological screening for infections, things like this. So just one thing you can remember, that if all is good, ultrasound scan from 32 weeks, any of these is not good. Either effective fetal weight is less or uterine artery Doppler is abnormal. Either of the one. You have to start scanning from 28 weeks itself. Here also serial ultrasound from 26 to 28 weeks. And here also, either of the two is bad, then you have to start scanning from 28 weeks until delivery. And if both are bad, then you have to discuss with fetal medicine because something is serious. So this was the surveillance in low risk, moderate risk, and high risk. Now, special category is where the woman is not suitable for monitoring of growth by SFH measurement, like BMI is very high, 35 or more, or fibroids are there, or congenital uterine anomalies are there, where symphysiofundal height won't work good. There, what you have to do? First, anomaly scan and fetal weight would have to be measured at mid-trimester scan. Means anomaly scan will be carried out and fetal weight you have to take out at mid-trimester anomaly scan. If all okay, then you have to again offer serial ultrasound scan from 28 weeks in those with congenital uterine anomalies, and from 32 weeks in the women who are unsuitable for SFH, like because of BMI and fibroids, every 4 weeks until delivery. So remember, in congenital uterine anomalies, the only thing you have to do is serial scanning from 28 weeks, every 4 weeks. And in women with fibroids and high BMI, again, SFH, those who are not suitable for SFH, of course, you have to carry out serial ultrasound scanning. In those with BMI high or fibroids from 32 weeks, in those from congenital uterine anomalies from 28 weeks. So this thing you have to follow routinely. Now, risk assessment is a thing that has to be carried out routinely throughout the pregnancy. So again, suppose she develops something new at 26 weeks or 24 weeks, then you have to keep on reassessing her for development of any new risk factors. So reassess at 28 weeks and after any antenatal admission. Anytime admission has been carried out, reassess her. Again, at routine, even if not admitted because of anything, you have to reassess at 28 weeks. Assess for any complications like hypertensive disorder or significant bleeding. And then according to this, you have to offer her serial ultrasound if required until delivery. So this is a thing which signifies that you have to keep on assessing her throughout the pregnancy for development of any new risk factors. Now, once the diagnosis is made, how will you assess her now? So either SGA or FGR, you have to offer her two things: effective fetal weight every 2 weeks, that is fortnightly, and umbilical artery Doppler. Through these two things, you are monitoring routinely any SGA and FGR. For SGA, EFW fortnightly and umbilical artery Doppler fortnightly. In SGA, both fortnightly. But in FGR, EFW fortnightly and umbilical artery Doppler weekly. So this is the main difference between SGA and FGR, that in SGA, both fortnightly, in FGR, EFW fortnightly and umbilical artery Doppler weekly. Now, first, let's see what happens in SGA. SGA is somewhat benign. It's not very pathological. So we can go on till 39 to 39 plus 6. Okay, after excluding FGR, at all times, we have to keep on excluding any Doppler abnormality, because if any Doppler abnormality occurs, she will jump to the category of FGR and then surveillance will be according to that. So keep on excluding any features of FGR and keep on carrying out fetal weight and umbilical artery fortnightly, and then tell her that it is good that we initiate induction of labor at 39 weeks so that birth should occur by 39 plus 6. So this you have to remember. And yes, one important thing here, after 37 weeks, an abnormal MCA, CPR or UCR, this you have to just remember few things about this, that MCA, CPR or UCR, you have to use after 37 weeks to decide the timing of delivery. No more than this. MCA PI if high, then you can plan delivery. That I will be dealing with shortly in further slides. But after 37 weeks, once she crosses 37 weeks, then these things you have to use for guiding the time of birth in SGA. Now comes the bad one, that is FGR. So in FGR monitoring frequency, what we are using umbilical artery Doppler, and depending on umbilical artery Doppler changes, we may or may not use ductus venosus Doppler. Now let's first see what results can be there of umbilical artery Doppler. Umbilical artery Doppler may be normal first, or it may be borderline. Borderline means PI more than 95th centile. If PI comes to be more than 95th centile, repeat this ultrasound scan with umbilical artery Doppler and DV Doppler and CTG every week. If it comes out to be pre-critical, that is absent end diastolic flow, then you have to repeat these two things, alternate daily, means minimum twice weekly, but call her at every alternate days or minimum twice a week. But if it comes critical, that is reversed end diastolic flow, then you have to call her daily for CCTG and or DV Doppler. In table, they have said that if AEDF or REDF is there, you have to call minimum twice weekly. Okay, you can't call her every week. You have to call her at least twice weekly. But exactly, it is good if you call her in AEDF every alternate day and in REDF daily. These can be the results of umbilical artery Doppler. Now, what can be the result of ductus venosus Doppler? It may be borderline. It may be pre-critical in the form of absent A wave, or it may be critical in the form of reversed A wave. Now let's deal with early FGR. Now early FGR, if it is happening up to 32 weeks. Any FGR, we are carrying out EFW fortnightly and umbilical artery Doppler weekly. If everything is going good, we will continue with this frequency only. But now, if AEDF or REDF develops in umbilical artery in between, then your frequency will increase from weekly to calling her at least twice weekly. And what you will do by calling her twice weekly, along with umbilical artery Doppler, you will put her on CCTG and or ductus venosus Doppler. If AEDF or REDF have developed, you will do these two things. In CCTG, that is computerized CTG, they are seeing short-term variability. STV is a parameter which is used to decide the timing of birth. Now, if these two features are there, you have to act according to gestational age. Between 24 to less than 26 weeks, if these things are happening, you have to take an individualized decision because viability is questionable. Between 26 to less than 29 weeks, what you have to do? If you will, AEDF or REDF is developing and you are monitoring them through these two, if at any time DV A wave becomes absent or reversed, or STV becomes less than 2.6 milliseconds, that is 26 here is there, STV less than 2.6 milliseconds. These two are indications, any of the two or both, then these are the indication of delivery. Deliver if this is there or STV less than 2.6. Whereas between 29 to less than 32 weeks, deliver again if DV A wave is absent or reversed, or STV is less than 3 milliseconds. So here in between 30 is there, 29 to less than 32. So STV less than 3 milliseconds. You can have an idea about remembering through this. Now, they have divided early FGR into these three gestational age groups. But at any time, if suppose she has become 32 weeks and REDF has developed, then you have to deliver her. Remember, deliver by 32 weeks if REDF, that is reversed end diastolic flow in umbilical artery, has developed. And even if it is developing 30 weeks onwards, you can consider delivery. So offer by 32 weeks, consider from 30 weeks. Delivery if REDF is there. Deliver by 34 weeks if AEDF is there. Similarly, for AEDF, these two gestational ages are 34 weeks and 32 weeks. Okay, so these two things are very important. And yes, in early FGR, input from tertiary level units with highest level neonatal care, multidisciplinary is very important. Also, you have to look for abnormal umbilical vein Doppler with pulsations. If any time umbilical vein pulsations are there, you have to assess DV waveform to decide delivery. And in between, if patient complains of reduced fetal movements, then you have to put her on CCTG again. Irrespective of all the things, if reduced fetal movements, CCTG is indicated in early FGR. Now let's come to late FGR. Late FGR, again, the monitoring is same, effective fetal weight fortnightly and umbilical artery Doppler weekly. What will you do if late FGR is there between 32 to less than 34 weeks? It is similar to before. If there is absent end diastolic flow, see, if there is reversed end diastolic flow, immediately you will deliver because she has crossed 32 weeks. If there is absent end diastolic flow, you can consider delivery, but you can also monitor minimum twice weekly with these two things. And when will you deliver? If REDF, then you will deliver, or DV wave is absent, then you will deliver, or STV becomes less than 3.5 milliseconds, then you will deliver her. And what about 34 to less than 37 weeks? Now, this is gone. Ductus venosus Doppler is gone. Now only CCTG remains. If AEDF is there, obviously you will deliver because she has crossed 34 weeks. Now you will look for only umbilical artery changes, that is umbilical artery Doppler, if PI becomes more than 95th centile. Now AEDF, REDF things are gone because if those are present, she is to be delivered without any second thought. But now what feature is requiring increasing surveillance? Umbilical artery Doppler PI more than 95th centile. That is the borderline feature there. If this develops, you will monitor minimum twice weekly with computerized CCTG. And now when you have to deliver, what is the delivery criteria? Of course, AEDF or REDF, or deliver if STV is less than 4.5. So here in late FGR, it is 3.5, 4.5. Between 32 to less than 34, STV is less than 3.5. Between 34 to less than 37, STV is less than 4.5. And yes, just like REDF was to be delivered by 32 weeks, AEDF was to be delivered by 34 weeks, umbilical artery PI more than 95th centile is to be delivered by 36 to 37 weeks. Again, if any time reduced fetal movements, you have to place her on CCTG. Now, in general, for all FGR, if at any time on CCTG there are repeated unprovoked decelerations, or suppose lady develops maternal indications, like suppose she has developed APH, she is bleeding heavily, of course you have to deliver irrespective of any other monitoring. And just like all SGA had to be delivered by 39 to 39 plus 6, similarly, all FGR have to be delivered from 37 to 37 plus 6. Here, as soon as they reach 37 weeks, you have to start counseling them to initiate induction of labor or LSCS according to whatever indications, and the delivery should be completed by 37 plus 6 weeks. So now what will you do 37 weeks onwards? Here again, the monitoring will be same, but between 37 to less than 39, deliver if AC or AFW less than third centile by 37 plus 6, just like we talked in the previous slide. Since here they are clear-cut FGR, they should be delivered by 37 plus 6. When FGR cannot be excluded, means controversial things are there, you have to discuss the management. And now at this gestational age, you have to use MCA. MCA, that is middle cerebral artery Doppler. And cerebroplacental redistribution, if any signs are there, counsel her to get delivered. At more than 39 weeks, again deliver if SGA by 39 plus 6 at all conditions. FGR was to be delivered by 37 plus 6 and SGA to be delivered by 39 plus 6. Now here, beyond 37 weeks, you can use MCA and cerebroplacental ratio less than 5th centile. They should determine the frequency of surveillance, and these should not be used prior to 37 weeks. So if at any stage you are initiating delivery because of these factors, you should not initiate before 37 weeks. You have to initiate after 37 weeks using these two parameters. Now, in this guideline, antenatal corticosteroids, again, they are saying to offer between 24 to 34 plus 6 weeks, ideally 48 hours before anticipated birth. Similarly, Maxulf is for neuroprotection. You have to offer between 24 and 29 plus 6 weeks and consider up to 33 plus 6 weeks, similar to earlier. Now deciding the mode of birth, it is very straightforward. They have said that if there is abnormal CCTG STV or any ductus venosus alteration or umbilical artery absent or reversed end diastolic flow, that is wherever there were things that deliver if this, deliver if this, deliver if STV is more than this, less than this, DV, ductus venosus A wave is absent or reversed, or umbilical artery absent or reversed and diastolic flow is there, means here baby has birth has to be expedited, baby has to be delivered quickly. So here they are saying that any of these conditions after steroids and MAC-self consider cesarean birth. Whereas if any SGA or late FGR is there with normal umbilical artery Doppler, or there is abnormal umbilical artery PI, but end diastolic flow is present, not absent or reversed, then you can induce labor, preferably with mechanical methods, with continuous FHR monitoring. However, risk of emergency CS is more in these cases, but still you can offer induction if umbilical artery Doppler is normal. Normal or only PI is abnormal and diastolic flow is present. So hope the guideline was clear. Let's come to quick questions like biometry in FGR should be repeated every. So just like we saw, biometry in SGA as well as FGR is to be repeated every 2 weeks. When can MCA, CPR or UCR be used to determine birth decisions? MCA always prefer after 37 weeks. Fetal infections are responsible for up to how many percentage of SGA fetuses? This is mentioned in this guideline, and 5% of SGA fetuses are because of fetal infections. Few one-liners like, yes, arrange first scan within the first how many days following recovery from serious COVID-19 infection. Suppose she has suffered from serious COVID-19 infection and has been discharged, then when you will call her for the next first scan, 7, 14, 21, 28, or no need of scan. It is 14 days following recovery from serious COVID-19 infection. Which out of these is least important risk factor for SGA? Cardiac valvular disease is there. If she is on anticoagulant use, it is a risk factor. Beta blockers are also a risk factor for SGA. Moderate or severe renal impairment is a risk factor for SGA, but IBD is less. See, the associations with asthma, anemia, IBD, and depression are less strong. They have said that there is weak or no association with asthma, IBD, anemia, and depression. So these are not considered. If they are uncomplicated IBD and adequately treated IBD or asthma or anemia or depression, then they are no longer considered risk factor for SGA. Now let's take some EMQs. A 32-year lady with earlier BMI 40, she underwent gastric band surgery. Now BMI is 32, she got pregnant, she is primi gravida. She underwent anomaly scan, which was normal, and EFW at 20 weeks, it was also normal. And she is asking, how would I be followed up for monitoring of the fetal growth? So now BMI is 32. It is not a risk factor now. And gastric band surgery, don't get confused. Gastric bypass surgery is a moderate risk factor, but not gastric band surgery. So here she would be treated just like low risk lady, and serial measurement of SFH would be carried out at each antenatal appointment after 24 weeks. So A would be the right answer. Bariatric surgery, gastric bypass has got higher risk. So gastric bypass, if she has underwent, then she would be classified as moderate risk. And if gastric bypass surgery was there, she would be offered ultrasound scan from 32 weeks, every 4 weeks until delivery. Similarly, if suppose her BMI was more than 35 now also, then again, since SFH would not be very useful for assessing fetal growth, so just like women with fibroids and BMI more than 35, same serial ultrasound scan from 32 weeks, every 4 weeks until delivery. Now let's see the second question. Mrs. Rosina, gravida 2, underwent first trimester combined test in which PAPI was found to be less than 5th centile. Now here it is an independent risk factor, high risk factor. She also has a history of small baby, low birth weight in her previous pregnancy. Now, what would you advise her? So here, first we will start aspirin. Now you may think that why aspirin here? But now, according to here in this guideline, it is given that women with a low PAPA or raised beta HCG level should be offered aspirin. So here we have to start her on aspirin, and since PAPA is less than 5th centile, is a high risk factor, we have to first consider prescribing aspirin according to this, and then she would undergo uterine artery Doppler in the anomaly scan. On evaluation of Mrs. Rosina, the previous patient, her uterine artery Doppler was found to be abnormal, but fetal weight was normal. Now, what would be further mode of monitoring? So, as we remember, if any of the two is abnormal, your ultrasound from 26 to 28 weeks will come into picture. So, any of the two is abnormal, either uterine artery Doppler or effective fetal weight is less. You have to offer serial USS from 26 to 28 weeks, every 2 to 4 weeks, depending on individual decision until delivery. So see here, abnormal uterine artery Doppler is there. So this thing is offered. But here, if suppose besides uterine artery Doppler, EFW was also less than 10 centile, besides abnormal uterine artery Doppler. So fetal medicine discussion would have been the correct answer. Now there is another lady, Ruby, who was referred because of suspicion of SGA baby by the midwife. See, she was on SFH measurement and she was suspected to have SGA at 28 weeks. Now when ultrasound was carried out, her effective fetal weight was less than 10 centile, but Doppler studies were normal. Now how should her further monitoring be? So she is SGA, but not FGR, because effective fetal weight is less, but less than 10 centile, but not less than 3rd centile. And there is no evidence of any placental dysfunction, no evidence of any Doppler abnormalities. So she is SGA. So EFW and umbilical artery Doppler both would be carried out fortnightly. That is every 2 weeks. How would you have suggested her monitoring if EFW was less than 3rd centile with normal Doppler studies? Now less than 3rd centile, even if Doppler is normal, she would be classified as FGR, that is fetal growth restriction. So her monitoring would now become EFW fortnightly and umbilical artery Doppler weekly, just like we discussed before. Umbilical artery Doppler weekly. Biometry in FGR should be repeated every 2 weeks and will be based on severity of FGR and Doppler assessment with a minimum of weekly when there are no other concerns, and 2 to 3 times weekly when there are umbilical artery Doppler abnormalities. And the next question, her next monitoring at 30 weeks showed absent end diastolic flow in umbilical artery. Now what next? So as we saw in the flow chart in early FGR monitoring, whenever absent end diastolic flow or reversed end diastolic flow is there, we have to start her on minimum twice weekly with DV and or CCTG. Either you will call on alternate days. If suppose it is written alternate day DV and or CCTG, then it would also be correct. At least twice weekly, she has to be called for these 2 things. If there is absent end diastolic flow. So the correct answer here would be monitor minimum twice weekly with these 2 things. Okay. Now, just some quick questions. If a woman is diagnosed as early FGR at 31 weeks, she was called for Doppler at 32 weeks, reversed end diastolic flow was found. With normal these things, we will obviously deliver her. Because at any time, if she's at 32 weeks or beyond and REDF is there, close your eyes and deliver her by cesarean section after steroid and Maxim. If she is diagnosed late FGR at 34 weeks, umbilical artery Doppler is showing PI more than 95th centile. That is, borderline changes have started. CCTG was carried out, which showed STV 4.8 millisecond. Now you remember, here there was 3.5 in late FGR and there was 4.5. So here STV is okay. So we can continue her monitoring. Since it's more than 4.5, so continue twice weekly umbilical artery Doppler and CCTG. And whenever this umbilical artery Doppler PI is persisting more than 95th centile, deliver by 36 to 36 plus 6 weeks. Okay. And if at any time AR EDF develops or STV becomes less than 4.5, then you have to deliver her. But beyond 34 weeks, ductus venosus, no role. Okay. If SGA is undergoing monitoring at 37 plus 2 weeks, she's at 37 plus 2 weeks, then how would you monitor and decide the timing of birth? You will monitor with umbilical artery Doppler, CCTG, along with MCA Doppler and or cerebroplacental ratio. Means umbilical artery Doppler is to be used, and if any confusion is there, you can use MCA Doppler and or cerebroplacental ratio to decide the timing of birth beyond 37 weeks. And at any cost, you have to deliver her between 39 to 36, 39 plus 6 weeks, even if MCA, everything is going normal. Yes, some of you might think what MCA Doppler abnormality will indicate abnormality, means what abnormality will be there in MCA Doppler so as to be called abnormal. So MCA PI will be decreased in placental insufficiency. Okay. Which serological screening holds importance in severe SGA? CMV and toxoplasmosis you have to do, and malaria and Zika only in high-risk places. And yes, which testing is to be considered with multi-system abnormalities? Suppose on anomaly scan, multi-system abnormalities or isolated short long bones are there. So it is especially specified that prenatal exome sequencing is to be carried out if any of the two are present. Otherwise, invasive testing like amniocentesis is to be offered for all severe SGA fetuses. Okay. This table is a quick summary of AEDF, deliver by 34 weeks, consider from 32 weeks. REDF, deliver by 32 weeks, consider from 30 weeks. Umbilical artery PI more than 95th centile, deliver by 36 to 37 weeks. All FGR, deliver by 37 to 38 weeks. All SGA, deliver by 39 to 40 weeks. DV, when you will evaluate, between 26 to 34 weeks, less than 34 weeks, you have to use DV, A wave absent or reversed for the timing of delivery. And what about STV? This confusing number, between 26 to less than 29 weeks, deliver if it is less than 2.6, 29 to less than 32 weeks, deliver if it's less than 3 millisecond, between 32 to less than 34 weeks, deliver if STV is less than 3.5 milliseconds, and between 34 to less than 37 weeks, you have to use 4.5. The 2.6, 3, 3.5, 4.5. These four numbers are important STV. And yes, in AEDF or REDF, you have to prefer C-section. Umbilical artery PI more than 95th centile, you can go for vaginal delivery. And in DV and STV abnormalities, preferably go for cesarean section. So that was all, guys. Hope I made SGA guideline. I tried a lot to make it a bit easier for you all. So hope it was helpful. So Anusha, anything else or should I end the session?